So today we'll be discussing about a very interesting topic in the Hrct chest, and that is pleural effusion and finding the possible underlying cause. Now the first thing is this is Hrct chest because this is right side, this is left side, and this is all lungs. HRCT, that is the CT scan, is basically an X-ray, and on X-ray we see air as black structure. So this all black is all air which is there inside the lungs. Now whenever we see, the bilateral lung field should be almost equal, but what we are seeing here, just see here, this on the right side the lung is pretty clear, pretty okay, but on the right side we are able to see very small portion of lung, and this is all uh, hyperdense or whitish structure. Now I told this thing so many times that the most dense white structure on CT scan is bone. The calcium is as white as bone because bone is all made up of calcium itself. And the third thing is blood, which appears dense white on the CT scan. So less whiter structure than the this bone or calcium or blood is either soft tissue, and the second thing is fluid. So fluid appears kind of white but lesser white than this typical bone. This is typical bone. These are the ribs. This is the rib. This is the rib, which is dense white. This is the vertebra, which is dense white. So soft tissue structure or the fluid appears white but not as white as bone. So this is a very typical whitishness, or this is typical hyperdensity of the fluid. So this is all water or fluid accumulated, So accumulation of the fluid in our outside the pleural cavity is what we call it as pleural effusion. So this patient has pleural effusion. So this pleural effusion is very much there on the right side, but on the left side there is a large pleural effusion on the left side. On right side, see, we can see these ribs. This is the rib, this is the rib. So there is no much accumulation of fluid outside the pleural cavity, but on the left side almost half of the lung is not able to visualize, and this is all uh, liquid or fluid which is accumulated and which is simply compressing the lungs. So we can see it here also, the pleural effusion is increased, so this trachea is slightly shifted to the right side. Just see this on here, the trachea is almost in the center, but here the trachea is almost shifted to the right side. Here also you can make out that this is the bone, this is the middle of the bone, so this is the middle of the sternum. So basically the trachea is shifted on the right side and the left sided bronchus can be seen here. So there is shifting of mediastinum toward the right side because of the pleural effusion. Now why do pleural effusion occurs? It's very simple. It can be transudative or it can be exudative. So what do you mean by transudative or exudative? It's very simple to understand. Transudate means whenever there is increased filtering of liquid from blood to outside. So whenever there is increased filtration, that time there will be accumulation of this fluid outside the pleural cavity. So this transudative is basically most of the time a systemic phenomena, whereas exudative is basically there has to be some local pathology, like there has to be some cancer, some lesion, some infection, pneumonia patch which is there, a trauma. So there has to have some local factor which actually irritates the pleural cavity or which actually irritates the lung and which causes increased secretion of a protein rich, a cellular rich fluid. So this exudative is always high with proteins. There can be pus, there can be increased proteins, and there is markedly increased cellularity. So you can see lot of pus cells, you can see lot of neutrophils, lymphocytes in this exudate, but in the transudate there is no actually infective focus or cancerous focus or inflammatory focus, it is actually a systemic cause like congestive heart failure. So what happens in congestive heart failure is left ventricle fails to pump the blood ahead to the aorta. So there will be increased accumulation of the fluid in the left ventricle into the left atrium. So automatically the pulmonary venules will have increased fluid accumulation. So automatically pulmonary capillaries will have increased fluid accumulation. So this capillary, they will be more leaky, and there will be leakage of this fluid from the pulmonary capillaries to outside the pulmonary capillaries, causing pleural effusion. Second thing, if the patient has nephrotic syndrome, so in nephrotic syndrome there is loss of so much of proteins, so the protein uh, quantity inside the blood markedly reduce. So automatically the oncotic pressure, or the pressure which keeps the fluid into the blood vessel, reduces. So there is increased leakage of the fluid outside the pulmonary capillaries. So congestive heart failure, LVF, then nephrotic syndrome, there will be a leakage of the proteins. In severe malnourishment, malnutrition because of the protein loss, the patient has hypoproteinemia or hypoalbuminemia. So why albumin is basically the richest, or the in the blood, whatever proteins are there, out of which almost 50 to 60% is albumin. So albumin keeps the fluid inside the blood vessel. So if albumin is less, if it is less than 3.5, the plasma oncotic pressure, which actually keeps the fluid into the blood vessel, reduces. So as there is this plasma oncotic pressure reduces, automatically there will be increased leaking of the fluid, and there will be pleural effusion. So CHF, nephrotic syndrome, malnourishment, hypoproteinemia. In so many cancers, the patients don't eat. In liver disorders, in CLD or in liver cancers, the albumin is markedly reduced, so it actually causes hypoproteinemia, hypoalbuminemia, and it can cause this transudative accumulation of the pleural fluid, causing pleural effusion. So whenever these are the transudative causes, we know it is a systemic problem. It is the problem in the blood vessel. So most of the time you will get this pleural effusion almost equal on both the side. So you will get right pleural effusion this much and left pleural effusion this much. So usually there will be almost symmetrical pleural effusion on both the sides if it is this systemic problem or transudative problem. But if there is exudative problem, or if there is a local pathology like there is pneumonia, there is METS, there is cancer, or there is some local inflammatory factor like trauma to one side pleura or one side lung, it will cause an exudative accumulation of these so many inflammatory markers, inflammatory cells. There will be large accumulation of the proteins, and in that case the effusion will be almost more only on the one side, and it will be much less on the other side, or there may not be anything. So in this case we can very clearly say, you can see, just notice here, there is mild effusion on the right side, but on the left side there is very much pleural effusion. If you see in here, the pleural effusion is very minimal on the right side, but on the left side there is marked pleural effusion. There is almost a moderate pleural effusion because it is coming from the base of the lungs to almost the apex of the lung. Here the apex is not visible on the left side because it is all filled with pleural effusion. So this more of a goes in favor of a local inflammatory pathology, and in almost 70 to 80% of the cases it is always a pneumonia causing local increased inflammatory cells and pneumonia. So this was all about today's talk, and thank you.